The COC exam is really tough, but don't worry because I have got you covered. I'm Victoria Mull. I'm a medical coder, auditor, educator, and content creator, and on my channel, I provide tips, tricks, and tutorials to help you be successful in a medical coding career. By the way, guys, if you want to become a certified medical biller and coder in 6 months or less without going into student loan debt, you want to take my free masterclass below. I share all the secrets that I've learned in the past decade, industry insights, the right way to train for medical billing and coding, how to save time and money, how to get a discounted training program, how to get a free laptop with your program, and much more. This masterclass gives you a complete roadmap on how you can be job ready as a medical coder in as little as 6 months. It seriously takes away all of the guesswork, so there is a link in the description, so go and register for it. Now, the COC exam made the same transition that AAPC exams made in 2022 in that it is 100 questions and you need to get a 70% or 70 questions correct in order to get a passing score. So I want to kind of start out by saying that a lot of people say that the COC and CPC are very comparable. I actually found the COC harder than the CPC, but in general, I would say about 75% of the content is the same as the CPC. The surgical coding, the medicine section coding, a lot of the ICD-10-CM coding, etc., is going to be the same. They're going to test you on a lot of the same concepts. So a lot of the materials that you have to study for the CPC can also translate into the COC exam, but there's a lot extra that they test you on for the COC. Now, I will be launching a COC preparation course that's an accelerated program in 2022. I don't have a solid date on that yet because I'm still working through a lot of the materials. There's a couple of different ways to study for the COC. So there's a full training program that you can get through like the AAPC. And there's basically 2 volumes that come with the COC curriculum. So there's volume 1 and volume 2. So with the CPC curriculum, they kind of start you out with like the business of medicine and the business of healthcare, and then get more so into a little bit about like Medicare and ABNs, and then into ICD-10-CM coding, CPT coding. The interesting thing about the COC curriculum is that when you start out with the COC curriculum, it starts out a little bit differently. It goes into a lot of payment methodology. So the first chapter in the full training is outpatient facilities and departments, business in the facility, CMS payment systems overview. So they're going to talk about charge masters. They're going to want you to know OPPS, the outpatient prospective payment system, and the difference between the IPPS, the inpatient prospective payment system. They're going to test you on the difference between the CMS 1500, or if you've been in the industry for a long time, the HCPCS 1500 form, and that compared to the UB04 form that is used for facility billing. So while they won't have you fill out a CMS 1500 form or a UB04, they do want you to know generalities about them. Same kind of thing with MSDRGs. You don't have to figure out a DRG, but they do want you to know what the components are that go into calculating the MSDRG. So if you're already CPC, there's just a lot of extra things that you need to learn in order to be successful to pass the COC. In the training manual, it even goes as far as to talk about compliance in the facilities, things like teaching facilities. So if you're working with residents, what the regulations are there, HIPAA, EMTALA, anti-kickback, STARK, ethics for medical coders, documentation, some of the specific things for outpatient therapies, radiation therapy. When I went into this exam, my mindset was, I'd worked a lot as a surgical coder. So I'm like, oh, like outpatient surgery, it's going to be a lot of that. That was a small portion of it, but it certainly didn't carry me through the entire exam. Now, in the full training program, once you kind of complete those sections, then it starts getting into a lot of the same stuff for the CPC. I actually compared the COC training manual to the CP training manual. So when you look at something like the integumentary system, when they're training you on the integumentary system, they basically took the exact same content that's in here, pasted in the COC, but there might be like an extra paragraph. Sometimes there's not even that, about some things that are specific to outpatient coding. So a lot of the content that's in the CPC book is exactly copy and pasted into the COC, but there's additional stuff in the COC. And then the interesting thing with the volume 1 versus volume 2 is volume 2 just kind of starts at the beginning of the surgical sections, and then it goes into, at the end, it covers outpatient prospective payment systems, CMS and inpatient payment systems, and Introduction to ICD-10 PCS and the guidelines. So it's very fascinating that it's not like, oh, this is the stuff you already get from the CPC and this is the extra. It's like really almost like this was too thick, so we just broke it into two arbitrary sections. Now, there is a study guide. The study guide is basically the abridged version. I think it is very possible, if you're already a CPC, to get the study guide and a couple of practice exams and see how you fare on that as far as studying for the COC. Some of the content is the same. I mean, there's no point in rewriting the exact same concepts and terms once they're already kind of done. So a lot of that general concept thing is going to be the same as the material that's probably in here or even the CPC curriculum. The test questions, the chapter review questions in the study guide are different. And there is a practice exam at the end. The interesting thing though about the practice exam at the end is it's 75 questions and they don't give you the rationale. They basically just give you an answer grid at the back. There are also some case studies in the study guide and some operative reports as well, and you will see case studies in the exam. We'll actually look over that in a second. But one thing I did want to bring you to your attention about the study guide that I found kind of interesting is that the practice exam at the end, there's like a handful of questions right at the end, questions 68 and onward to 75 is just categorized miscellaneous. There's also in the practice exam in the study guide 10 questions on medical terminology and 10 questions on ICD-10-CM, which I think is kind of interesting because let's actually look at the exam breakdown. So if we look here, and let me take myself out of the equation here, there are 7 questions on medical terminology, 7 questions on anatomy, 3 questions on coding guidelines, a lot of questions on payment methodology. Look at that, 13 of the questions are on payment methodology, 3 on compliance, 15 on ICD-10-CM. So that's interesting. There is a fair amount of ICD-10-CM on this. 13 questions on CPT, just like I guess all of CPT. And then HCPCS level 2 coding is 7 questions, surgery and modifiers is 22, and then cases, which is interesting because that's what we saw in the CPC exam as well. They have 10 cases at the end. And again, you can see in the study guide there, they have a section that is designated cases, and those are similar to these types of cases that you'll see in the COC exam. And since they are likely going to be longer in length, those are the questions we probably want to wait until the end to finish because they're going to be more time involved than something like a midterm question that you already know. Now, I'll link this below as one of the resources, but if you want to get all the details about exactly what is going to be covered in these sections, it is on the AAPC website here. So you can see there's going to be just 7 general medical terminology questions, anatomy, but then here when you start breaking down some of these, they give you some more information. They're going to want you to know about the guidelines and the parenthetical notes. They want you to know about, here we go. This is what they want you to know about the payment methodologies. The differences between Medicare Part A, B, C, and D, right? The differences when you have Medicare as a secondary payer, a UB04 versus 1500, which we talked about. And a lot of this stuff are things that you'll want to know in how to guide to in your HCPCS manual, which we'll look at. So the OPPS, Outpatient Prospective Payment System, ambulatory payment classifications, revenue codes, status indicators, payment indicators, condition codes, calculation of proper payments from Addendum B and Addendum AA. Those are provided on the exam. The IPPS, Inpatient Prospective Payment System Methodology, Inpatient Prospective Payment System Payment Methodology. Okay, so what do you need to calculate a DRG? Code sets required for inpatient claims. Reimbursement for a teaching hospital, so when you're working with residents, charge description masters. Compliance is going to be targeted more towards national coverage determinations and local coverage determinations, HIPAA and ABNs. ICD-10-CM, kind of self-explanatory. CPT, now this is important to note. It's not going to necessarily be everything in CPT because not necessarily everything is an outpatient procedure, right? So these are the targeted sections in CPT that they're going to go over. There are going to be some emergency department questions, some outpatient clinic observation, critical care. So there are going to be some E&M, but they're targeted. And I'm going to go over a question with you that's going to show one of the key concepts that they like to test you on in the exam. Not necessarily saying this is the exact same question or I pulled this from, but it's the concept is one that they like to test on. Surgery, there are going to be some surgery codes. I have I have found it very helpful if I'm doing something like I'm doing multiple lesions to take highlighters so that you can designate which areas certain lesions are in and designate which potentially repairs you could combine, because sometimes if you have a repair that you're doing on an arm and a leg, you can combine them if they're the same complexity of that laceration that you're repairing. So, sometimes highlighters can be helpful in this exam more so than some of the other exams. There's going to be a lot of radiology stuff, lab and path, and then medicine as well. So HCPCS, you definitely need to know some of those sections of your HCPCS book because they're going to test you on some of those insurance-specific codes, as well as the HCPCS modifiers, medication, supplies, surgery and modifiers. So of course, we're going to focus on the things that are for outpatient facility, things that are commonly done in ambulatory surgical centers, when we're billing for those facilities, and then 10 cases. And those 10 cases are going to test you on a lot of different medical records that you would see in an outpatient facility. I just paper cutted the heck out of myself grabbing my HCPCS book. That is one of the dangers of being a medical coder, right? Those paper cuts. Oh, that stings. The HCPCS book is one that you really, really need to know for your COC exam because the layout of this is going to be very, very helpful. Now, right now, I have the Optum 360 version. Depending on what version you have, and I don't actually have any current other versions of HCPCS, so I don't know how all of them are laid out, but know the layout of your edition of HCPCS because it's going to be super, super helpful. Now, if you watch the other video I did on the COC exam and my experience with it, you'll know that I used to have a book that had all of the, like a listing in one of the appendices of the payment status indicators, but a lot of them now just have like a legend and they have icons that you can see. So here in my book, here is the OPPS status indicators, and it tells you all of the definitions here of the different payment status indicators. So there might be a question on the exam where they ask you about what sort of payment status indicator a code has. And if you see that little C on there, then you need to know where to reference what that C means, and that you can go to this legend and go, oh, okay, the C means it's an inpatient procedure, and that's a procedure that has to be done on an inpatient setting. So you really need to know that, the OPPS status indicators. The other thing, and again, I don't know how all the other HCPCS books are laid out, if they're the same as mine, but really look at your HCPCS book. I know you barely needed it for your CPC because there was, like 3 questions, but you're going to need it more so for your COC. So make sure that you know the layout of it. So here we have our ASC payment indicators. So these are different. Don't get them confused, but these are the ambulatory surgical center payment systems. So they might, again, give you a CPT code and you have to look it up, and it might have a C5 next to it, and you need to know, oh, look, there's my paper cut, that is an inpatient procedure, right? So knowing that, you can reference this legend, knowing where this is and where to find those information so that you can answer those questions accurately. This is one where even if you've been coding for a long time, I would highly suggest you really go through those sections heavily that are the things that are different from what you might know in a CPC setting. A lot of those payment methodology questions are the things that you are really going to need to focus on because they're not going to be something that you'll have been trained on in a professional coding setting. Let's go over some practice questions, and this one is a perfect example. What type of coding is utilized to determine MSDRG? Now, there's a lot of things that factor into an MSDRG, but this question is asking us about the type of coding. So A is risk adjustment, B is CPT, current procedural terminology, C is ICD-10-CM, D is ICD-10-CM, and ICD-10-PCS. PCS is our procedural coding system. So when Medicare uses those MSDRG is the Medicare Severity Diagnostic Related Group, and those are used to calculate inpatient payments. And the way that they are grouped together is using ICD-10-CM, using ICD-10-PCS, age, sex, complications, comorbidities, signs and symptoms if the diagnosis is not yet known, and then the discharge disposition. So what type of coding is going to be utilized to determine that MSDRG? We're going to use our ICD-10-CM and our ICD-10-PCS codes. Now, this question here is really testing on your knowledge of the coding terminology. So it says, what type of code designation should not be reported in addition to the code for the total procedure or service of which it is considered an integral component. So it's asking us for a definition. So is this what they're asking here? Is this the definition of a parent code, of an evaluation and management code, of an excludes to code, or of a separate procedure? So this is really a terminology question. Do you know your coding terms? So excludes to is an ICD-10-CM term. The others are CPT terms. Parent code versus child code. Evaluation and management is a type of coding. Separate procedure. You can actually find the definition for separate procedure in your CPT manual. It is in that first page or two of your surgery guidelines is the definition for separate procedure, and that is the one that should not be coded when it's considered part of an integral component. So this is what this question is asking. What type of code designation should not be reported in addition to the code for the total procedure or service of which it is considered an integral component? That is our definition of a separate procedure. So really, really knowing not just, the code lookup concepts, but really knowing how the definitions work and the different payment methodologies we're seeing here. Now, this question, if we look at it, this one is a key one. I know that they like to test on this concept heavily in the materials to prepare for the exam. So that in my mind triggers me to know that there's a higher likelihood that this concept will also show up in your actual exam. And what it's asking is a Medicare patient is seen in the hospital clinic for follow-up for diabetic foot ulcer of the left foot with muscle necrosis. The medical decision making was moderate. Code for the facility services and diagnoses. So we're coding for facility services. So here's our key thing, facility services. And we're also coding the diagnoses, which, obviously they have diagnoses in all of them. So regardless, we're coding the diagnoses. But there's another key thing that we need to pull out of here. Actually, two key things that we need to pull out of here. First is this is a Medicare patient. And if it's a Medicare patient, we always have to be very careful when we see that it's a Medicare patient, because Medicare has some of those codes, like G codes, that are Medicare specific. So sometimes when they include in there, oh yeah, this is a Medicare patient, they're trying to clue you in like, hey, this might be one of those Medicare codes. So that's something to kind of draw your eye to when you're looking at these cases, things like Medicare patient. The other thing is the word clinic. So oftentimes when you see clinic in these questions, they're asking you about the facility services. Okay. So this question here, we have these answers. And if you look, the diagnoses are the same. All of them are E11, 621, L97423, because that's not really what we're focusing on for this concept. We're focusing on, is this going to be an E&M? Is this going to be this G code? Or is this going to be, let's see, this is an inpatient versus the outpatient E&Ms. So really testing you on this concept of, is this visit an E&M, an outpatient E&M? Is it an inpatient E&M, or is it this G code? So the key thing to really, really focus on here is that word clinic, that clinic word. So if you actually go into your HCPCS manual and look under the word clinic visit for the hospital outpatient, it sends you to code G0463. And that's our answer B. So really what they're testing you on is knowing when to bill that G code versus when to bill a E&M code. And they might even try to trip you up like this, because look, they put in here like that this is a moderate visit. You see this? It says moderate. So you might just look at this right away and think, oh, it's a moderate visit. This is probably a patient who's a level 4 visit, but we're not coding that. We are coding the facility clinic fee, the G0463. So if you look in your HCPCS book, you might even want to write that down, like maybe even in your E&M section, make yourself a note like, hey, don't forget, if this is a Medicare clinic visit, we're doing the G0463 code. So that's a concept you might see. You might also see that they'll test you on your emergency departments. So the difference of the emergency department, how to level those ED visits as well. Now here's another one. Remember, we talked about that they're going to test you on modifiers. So knowing your modifiers, knowing which ones are outpatient modifiers, which ones are appropriate for inpatient, etc. Now this question is testing you on your modifier knowledge. And don't forget, on your front flap of your CPT book, there is a section there that says modifiers approved for hospital outpatient use. So if they test you on something and say, is this approved for hospital outpatient and it's not on this list, there's a good chance it might not be approved for hospital outpatient. And again, your HCPCS book is going to be so critical for this. There's a lot of modifiers in your HCPCS book that aren't in CPT because they are modifiers for HCPCS level 2. I am telling you, you need to be very familiar with your HCPCS book and the layout and where you can find things in your HCPCS manual for the COC exam. And again, mine, I have the Optum version. Yours might be laid out differently. My modifiers are in Appendix 2. So I've had some that had very different appendices. So make sure that you are familiar with what is in your edition of the HCPCS book. But going back to our question, a 72-year-old Medicare patient has a right carpal tunnel repair. Right carpal tunnel repair. Right carpal tunnel. Right carpal tunnel repair at an outpatient surgery center with Dr. Chen. 6 days later, he suffers a fall and Dr. Chen performs a fracture repair of the left tibia in the hospital OR. What modifier should be used on the fracture repair code? So this was our first surgery. And they're likely in a 90-day global, right? 90-day global. And 6 days later, while they're in that 90-day global, they fell. Now, was this fall related to the carpal tunnel repair? No. This fracture that they're having was repaired because of this fall. That fall and wasn't a side effect or impacted or caused by this right carpal tunnel repair. So is this fracture repair related to the carpal tunnel? No, it's unrelated. So we have different modifiers needed for if it's related, unrelated, etc. So if you're looking at these answers, 78, 79, 58, those are some key components you want to know. And remember that you can find your short definitions of your modifiers in your front flap, but where are your long definitions of your modifiers? They are in Appendix A of your CPT manual. So you might want to, if you have a case where you're kind of like, could be not, make sure you know to reference Appendix A in your CPT manual to find that. Now, so is this related or unrelated? Unrelated, we've determined that. So let's look at some of our modifiers. So 78 is an unplanned return to the operating room. Okay, we're good so far on that. By the same physician or other qualified healthcare professional following the initial procedure for a related procedure during the post-op period. Well, this wasn't related. 59 is unrelated procedure or service by the same physician or other qualified professional during the post-operative period. There we go. We had an unrelated procedure during that post-operative period, so that would be our 79. 58 is if it is a staged or related. So I think some of the situations where we maybe wouldn't need a modifier is if they're outside that global period or it's a different provider, right? So if it was a provider that was completely not connected to Dr. Chen, they're not of the same facility, they're not working for the same guy, for the same healthcare system, then we wouldn't need a modifier if it was two totally unrelated surgeons. In theory, I mean, we all know that insurances don't always process things according to necessarily the coding guidelines. So let's now look at this one here. 52-year-old female patient is being examined for facial nerve paralysis by the clinic's otolaryngologist. The provider conducts facial nerve function studies by performing an electron neuronography. The study determines the patient has an inflammation of the tissue in the facial nerve determined to be Bell's palsy. What CPT and ICD-10-CM codes are reported by the facility? This is another one where they're like, hey, we might be trying to trick you into thinking that this is a visit code. Should we tack a visit on this? So this one, it looks like some of these are kind of the same. Look at this. So this and this are the same. This and this are the same. Here, this one has the E&M attached to it. And here we have a new patient E&M attached to it. And then here we can even see this and this are the same. And this and this. Oh, no, wait. That's not the same. A little bit different. 1 digit. Okay. So if we piece this together, first off, my question would be, is an E&M here appropriate? Should we be billing an E&M here? And it looks like what they did here doesn't have an E&M code. So I right away am like, no. I don't like A, I don't like B, because I don't think we should be tacking an E&M on here. I'm not seeing medical decision making to support anything other than this study being performed. Now I'm just getting crazy with the doodles. So we're looking at C or D. So if we look up in our CPT index and we go under facial nerve and function study, what it's going to take you to for that is CPT code 92516. So once you look at 92516, you can verify, oh yeah, that's correct. And then also the code for Bell's palsy, you would look it up in the ICD-10-CM alphabetic index. It's under Bell's palsy, comma paralysis. And that directs you to G5 1.0. So we know that that is correct. So even if we just looked up kind of the diagnosis code, we could put that together and that this is the correct answer. But definitely if we look up the code for the facial nerve function study, it's going to take us to that 92516 code. So that's how we know that this is our D. Now, as far as other references for the certification exam, make sure that you reference those FAQs that the AAPC has, and I'll link these below as well. And check the approved resources, because you don't want to show up thinking that there's extra books you can take and you're not allowed to have them, or you think that you aren't allowed to take something that you are in fact allowed to take. So I hear a lot of people say those icons are so hard to see, so you are permitted to take something like a magnifying glass if you need to see small print. And reference back to that section on the AAPC where they specifically talk about the COC exam, because it's going to give you a lot of information about the exam breakdowns. It's going to give you some resources, some direction onto where to purchase some of these study materials as well. So while it is a difficult exam, it is definitely not an impossible exam. You really just need to understand what it is that they are going to test you on, the concepts, the terminology, and those additional things above and beyond what's going to be on the CPC. If you're thinking about getting your COC this year, you can also check out the video that I made over here on my experience taking the COC. I will see you guys in the next video, and until then, just keep on coding on.